Hello, and welcome to the webinar. My name is Julia Shida, and I will be acting as moderator for today's webinar titled Needs Assessment for Healthcare for the Homeless Grantees, Meeting HRSA Requirements, a production of the National Healthcare for the Homeless Council with support from the Health Resources and Services Administration, Office of Special Population Health. This session is being recorded. This is a 1-hour presentation with the last 10 minutes reserved for Q&A. Below the presentation slide, there is a Q&A pod for participant questions and technical issues. Please type your questions or technical issues into the Q&A pod at any time during this presentation. A selected number of questions will be answered at the end of the presentation during the Q&A session. The PowerPoint presentation and the recording of this webinar will be posted on our website at www.nhchc.org within 72 hours. The National Healthcare for the Homeless Council has had a recent surge of requests for technical assistance from existing and prospective grantees to help these organizations meet HRSA's Needs Assessment Program requirement. The Council has received other requests more generally to help individuals develop their community needs assessment. These requests range from information on how to collect data, how to use the data to assess the need of the homeless population in the community, and even where these organizations can go in their community to survey the population and potential clients of the health center. And we've also responded to direct requests for data specific to the local communities. Our hope is that this webinar will not only provide some basic concepts of needs assessment development and use within health centers serving individuals experiencing homelessness, but also practical suggestions for you to use in your community. We have tailored this presentation to both existing and potential grantees or organizations applying for lookalike status. The Council is continuing to develop resources on this topic, including a Needs Assessment Toolkit, which is currently being reviewed for approval by HRSA and should be available to the public in the coming weeks. We always encourage individuals to request TA from the Council, whether it's a simple request that we can respond to with a quick email or requires a more in-depth conversation with one of our technical assistant consultants. You can submit a request for more information and guidance around this topic through our online TA request form. The link to this online form will be listed with other needs assessment resources on the resources slide after the live Q&A session at the end of this presentation. The Council specializes in peer-to-peer technical assistance and trainings, so we have invited experienced Healthcare for the Homeless administrators and individuals currently working within Healthcare for the Homeless programs. These presenters come from different program and funding landscapes, which we hope will highlight some of the similarities that different communities will have in meeting the HRSA Needs Assessment Program requirement, regardless of program type, although you will hear terms and ideas that may be unique to certain types of health center programs. I'd like to go ahead and introduce our presenters. Lee Carroll, LCSW, President of Lee Carroll & Associates, has over 30 years of experience in primary care, behavioral health, and social services. Experience includes hospital administrator, regional vice president of a faith-based multi-state social service agency, and 16 years as executive director of Healthcare for the Homeless of Milwaukee, Incorporated, which later became dually certified as both a 330H and 330E, and known as Outreach Community Health Centers Incorporated. Throughout her career, she has been successful in organizational development and instrumental in organizations reaching their potential. She currently provides consultation to nonprofit organizations in the areas of management, strategic planning, grants and resource development, organizational compliance with funding sources, and program development. On a national level, she has provided technical assistance to both community health centers and Healthcare for the Homeless programs in grant development, technical assistance, and operational site reviews. She's approved for objective grant reviews for both HRSA's Bureau of Primary Health Care and SAMHSA, Substance Abuse and Mental Health Services Administration. She's also contracted with Family Enterprise International to provide emergency crisis response services, to provide service coordination and behavioral health services. Local non-healthcare services includes a contractual consulting relationship with a sustainable energy nonprofit organization and their expansion to include integration of wellness services into their service continuum. She has been a speaker and trainer on federal grant development with the Milwaukee Nonprofit Center. Our second speaker, Erika Barber, has 8 years of experience managing state and federal grant programs for Boston area organizations serving the homeless. At Boston Healthcare for the Homeless program, she works closely with project directors to ensure programmatic accountability for all HRSA grants, including the Public Health Service Grant, Ryan White Part C, Ryan White Part A, and special projects of national significance. A licensed attorney in the state of Massachusetts, Erika chairs Boston's Healthcare for the Homeless program's Corporate Compliance Committee and oversees related efforts and investigations. Our final speaker, Victoria Deloney, is a bachelor-prepared registered nurse and has an MBA with an option in healthcare management. She's employed with the County of Sacramento Department of Health and Human Services in the Primary Health Services Division. She currently is responsible for daily operations for the Healthcare for the Homeless grants clinical and field activity and grants management. She has worked with the Healthcare for the Homeless program for over 12 years. Additional healthcare background includes skilled nursing, oncology nursing, and public health nursing and health home director. Victoria is a member of Sacramento Steps Forward's Homeless Healthcare Committee, Sacramento Alliance to End Homelessness, and Sacramento County Medical Reserve Corps. Today's agenda includes an overview of the Needs Assessment HRSA program requirement, its relation to the needs section of grant and look-alike designation applications. We will also discuss the needs assessment and how it can impact your organization's strategic planning process. Lee will also share some things to consider for healthcare for the homeless providers attempting to assess local need. Today we will be spotlighting 2 healthcare for the homeless grantees. Our first case study is Boston Healthcare for the Homeless. Erika will review the who, what, when, where, and how of their needs assessment process. Our second case study is Sacramento County's Healthcare for the Homeless program. Victoria will be giving us detailed information about their satisfaction survey for their needs assessment. You can download a copy of their survey in the Documents pod that is located below the slide presentation and to the right of the Q&A pod. Following the presentation, we will have a live Q&A session with our speakers. After the Q&A session, we will share additional needs assessment resources, then close out the webinar. Without further delay, I would like to pass the mic to our first presenter, Lee Carroll. Lee?
Thank you, Julie. Good morning or good afternoon to everyone, depending upon where you're located, and welcome. As Julie stated, I'm Lee Carroll, and I'll be giving you more of a basic overview of the needs assessment process as it's related to HRSA requirements and funding of the program. On our first slide, it's the importance of the needs assessment. HRSA makes a general requirement. If you look at I don't know if you're familiar with the site guide, the health center demonstrates and documents the needs of its target population, updating its service area as appropriate. Also, when you look at the grant application process, HRSA will identify a needs section that must serve as the basis for, align with the proposed activities and goals described throughout the application program requirements. The main thing that we want to talk about is how this forms the foundation of the program and that it permeates each of the 19 HRSA program requirements. I can't stress enough the importance of a well-defined needs assessment as it truly impacts every area of your program. It's also integrated in every response and aspect of your grant application. So a well-defined needs assessment has to be able to relate back, every aspect of your grant has to relate back to that needs assessment. The needs assessment also is used to determine whether or not you have identified a needs assessment and whether or not you've identified the needs of your target population. For example, does your program or proposed program reduce barriers to health care, and does it address the gaps in the health care delivery system? In addition to clinical aspects, you'll be asked to identify things such as ethnic, cultural, attitudinal issues of your target population, and there'll be other issues such as linguistic needs of your population. And that may be on a temporary basis, such as if you have a refugee resettlement program or if there's an influx of immigrants in your community. And also not to forget some of the special needs of things, people such as those that are deaf or hearing impaired. The other area that you're going to need to address is your program located in a health professional shortage area? Does it address the needs of a medically underserved population or medically underserved area? In addition to that, you're going to need to, in your health professional shortage area, there may be providers available, but are they willing and able, and do they have experience in meeting the special needs of the homeless population? Specifically to the homeless, is it geographically accessible to that target population? The homeless really have to rely on themselves to move from location to location, as we know, and even though there may be public transportation, they may not be able to afford to access public transportation. As a result, you may have satellite clinics located, for example, in shelters. If you're having a clinic located in a shelter, is it accessible to meet the needs of that population? Do you have early morning hours, for example, to provide services to the guests before they leave for the day? And then again in the evening when they come in for the overnight experience. In addition to the geographics of the target population, there's a need to identify how you identified the target population to begin with. In addition to using things such as the continuum of care that's available through the HUD program, you may use other mechanisms such as focus groups, maybe a consortium of other community providers. One area that I've used in the past is a consortium of free clinics, for example. You may want to also access information from a task force on domestic violence and to work with the public health departments because they provide very good information on the needs of the community. For existing grantees, remember that the needs assessment is a process that you need to re-examine periodically. One of the things that all grantees are going to face in 2014 is that they're going to need to address the impact of the Affordable Care Act on their program. For example, will there be more or less patients that are accessing services through their resources? Will it have an impact on revenue? And will it have an impact on recruitment issues? Another major area that you would look at in terms of a needs assessment is a major change of employers in the community. For example, if it's a community that's reliant on a major employer and that employer leaves the community, what will be the impact on access to health care and employment and the economics of the community? About a year ago, I was at a site where a major employer group had left 30 years ago, and the community has still not recovered 100%. And what we're seeing in that community is a population, for example, that is aging in place because they have not left. So the services needed will have to be adjusted to meet that population's needs. Another issue may be the closure of a hospital and the impact on the lack of an emergency department on access to primary care services. And the other issue that seems to be happening in many cities around the country is the downtown area where homeless had congregated has now been replaced with upscale condominium development, needing the homeless providers to possibly move their location in order to accommodate the homeless that have now been moved to another site. As we said before, the needs assessment really plays a major role in your organizational strategic planning process, and that you have to remember that in the process that although HRSA may have some very rigid requirements in terms of the development of a needs assessment, that your needs assessment is really the heart of your program. And the overall goal is to make sure that there's 100% access for those who need services regardless of their ability to pay, and that they should have access to quality health care. For new grantees, I just wanted to talk a little bit about the grant application process. The needs assessment is a major portion of that application, and if you look at the guidance, you're going to see that the scoring presents that it's going to cover 15 to 20 of the 100 points used for the scoring of the application. When you look at the next section in the guidance, it specifies the response, and HRSA indicates that there's a direct correlation, of course, between the needs assessment and the response to the needs of the target population. It's difficult to look at one without the other, so that essentially you're looking at two parts of the application that are so intertwined that they really represent about 35 to 40% of all the points in the application. So you really need to have a very solid needs assessment in order to respond to that. Remember also that the next 5 sections, I believe it's 5, also have to relate back to the issues that you identified in your needs assessment. So your health plan, your business plan, everything revolves back to that initial needs assessment. One of the things that I'm sure many of us dread having to do repeatedly is the dreaded Form 9. This is the form in the grant application that addresses all the core barriers that are addressed as part of the needs assessment. It's required of all grantees. Doesn't matter if you're a traditional community health center or if you're serving a special population. Every grantee must respond to the same issues. The one thing that's a concern to those of us who have worked more closely with homeless programs, however, is that although there are national norms, many of them vary for the homeless population, primarily because the homeless are entering the system with a higher level of chronicity for their health condition than most of the mainstream patients. One of the things I want to do is provide some resources for you. Rely on some, as we said, the National Health Care for the Homeless Council provides a great deal of resources in terms of how to find information about programs and to respond to the needs assessment. Some of the other sources that you have are your primary care association. Some PCAs are have more information about homeless programs than others, but I would also use those. Other areas that you're going to rely on are census data, your state and local health departments, of course. Your state immunization registries will provide you on information on immunizations, and a state hospital association may be able to provide some information. Your UDS mapper, and HRSA also provides what it refers to as health center data statistics. There's a link in the application process, I believe this time as well, that will provide a link directly to the HRSA health center data statistics. As I mentioned, for many of you, I'm speaking to the choir, but excuse me. There are certain health indicators that we're all asking to respond to, and I think that we need to look at some of the special issues that are related to the homeless. For example, an insulin-dependent homeless diabetic will have an issue related to access to insulin and storage of their insulin and their supplies. If you're a health educator and you're doing diabetes health education as a homeless provider, remember that your population cannot eat at regular intervals and that they also rely on meal sites for meals and shelters, which means that they're heavily laden with carbohydrates, and we know what that means to working with a diabetic. There's also the issue of the impact on other health conditions. For the homeless diabetic, there is the issue of foot care and wound care and the impact that exposure has on circulatory issues as well. Another area that is very common to homeless providers, of course, is the level of mental illness that's present in our population. Also faces the lack of medication to stabilize their condition. As healthcare for the homeless providers, remember that you are mandated to provide access to substance abuse treatment. Those of us who work with the homeless mentally ill realize that probably at least 50% of that population has a co-occurring substance abuse condition. As homeless providers, you must either provide access to substance abuse treatment or have a formal relationship with another community provider to make sure that that service is provided. As I said before, the impact of homeless conditions on other health conditions is important to take into consideration. For example, in the mental illness, as they're coming in as a more chronic issue, the type of medication that you're using to manage their mental illness may also have an impact on other health conditions, such as if you're using an atypical antipsychotic medication, it may have an impact, for example, on blood sugar levels and impact on diabetes. Other issues that I want to present, just touch on, and I believe that there'll be more information from Erika, is that it's my understanding that homeless patients have a much higher incidence of physical and sexual abuse. I've heard it reported that it's 6 times greater in this population than it is in the mainstream population. Also, exposure and skin disorders that are prevalent in the homeless population that will not be even presented at all in the general population. So last slide, one of the things I want to talk about just a little bit is the looking for information about homeless. Many people are directed to the continuum of care process, and that is a good process using especially the Exhibit 1, which kind of consolidates all the information from the community. But also remember that it's not exhaustive in terms of information. There are certain areas that won't be included in that that will impact the number of homeless people in your community. For example, it may not have listings of use of temporary settings to address overflow issues such as churches and so forth. Domestic violence programs may not participate in this process. Also, doubling and tripling up, I would use the resources such as the National Council to help you look at how to come up with a number that reflects the doubling and tripling up in your community. Also may not address the number of people who are located in encampments. Also to tell you that we have the opportunity now to use supported permanent housing, and those residents can be included now in your needs assessment. The biggest drawback that I have noticed in using the continuum of care is its lack of documentation and the intensity of primary health care conditions. So you'll need to rely on other resources than that to identify the health conditions of the homeless population. Well, that concludes my portion of the presentation. And at this point, I'd like to pass the mic on to Erika, and she can provide you with some specifics about the Boston Healthcare for the Homeless program. Thank you.
Good afternoon, and thank you, Lee, for your presentation. Thank you for having me today on the webinar. I am presenting from Boston Healthcare for the Homeless program. And first, a little bit about our program. Our mission since 1985 has been to provide and assure access to the highest quality health care for Boston's homeless men, women, and children. And last year in 2013, we served 12,581 patients, and with our subcontractors, we served a total of 14,867 patients. So I imagine we're probably one of the larger healthcare for the homeless programs in the country, but I'm not sure, so you could think about the size of your program and think how it might relate to the size of mine as I'm giving the presentation. So to get into the topic, the HRSA site visit requirements is where I would start if I were considering a needs assessment. And one thing to keep in mind is that you need a comprehensive justification for your existence and structure. When compiling a SAC application, you need to always explain why another group couldn't serve your population better. And the same goes for new grantees. You really want to be able to describe the needs of your population and why your organization is best suited to meet those needs. So there's really 3 questions that I would ask myself if I were preparing for a site visit with respect to the needs assessment. That would be first, does my health center have a written needs assessment? And if you don't, that's okay. I think there's ways you can meet that need in both the short term and the long term. If you do not currently have a written needs assessment and you find yourself coming up against a deadline for a HRSA site visit, you may want to consider looking at other documents your health center has prepared. Almost all nonprofit organizations have a strategic plan. Perhaps this strategic plan has information on needs of your patients, your staff, or your general community. If that's the case, you could copy relative portions of this strategic plan and ask your CEO or board of directors to recognize this portion as a needs assessment in the short term. The second question I would consider is, does my health center have a defined service area? If you're already organized as a health center, I would imagine you do. So the third question is the service area consistent with the patient origin data in UDS? And for those of you not familiar with the UDS, that would be the zip code chart in that UDS report is where the patient origin data is located. So when considering the need for a new needs assessment or before a site visit, you'll just want to check to make sure your patients are really coming from the area that you indicated they would be coming from. If you find a disconnect and you find it's inconsistent with the patients you're currently serving, you may want to ask key staff, are we doing all the outreach in the areas we need to connect with our target population? If you find yes, then your next step is most likely to go to the Consumer Advisory Board and to the Board of Directors to ask, is it time to reevaluate our service area? And how will this affect our funding if we do present this to our project officer? And my final note on that is your project officer is there as a tool, and they're very helpful, and so it's always good to reach out to your project officer if you find inconsistencies. For my next slide, I'd like to just briefly touch on the documents to prepare prior to a site visit. Boston Healthcare for the Homeless is expecting a site visit in 2015, so I'm starting to prepare some of the documents now. The ones I would prepare are right here on the slide for your review. Okay, so now to discuss how do you actually conduct a needs assessment. First, you'll want to consider who to include in the needs assessment. In our most recent needs assessment of 2010, we included 4 major groups. These target audiences were health center management, health center staff, key external partners such as shelters, health providers, government organizations, and health affiliates, and finally the Health Center Consumer Advisory Board. And one note on that, if you do not yet have a Consumer Advisory Board, it would be great to form one, but in the short term, you could work with any other group of patients you may have who provides regular guidance to your board of directors. Now for how to conduct the needs assessment. Our most recent needs assessment took about 6 months to complete. So that's one thing you may want to think about in terms of planning when to do one. You should probably plan it 6 to 12 months before your SAC application is due or before your next site visit is scheduled, and all of you should have individual deadlines for those events. The way we did our most recent one was we used 4 major components, and these were with the 4 different target audiences. First, with our staff, we use surveys. We use both paper and online for outreach sites that may not use internet connection as much, and for the main site, we used mostly the online survey through SurveyMonkey. And in these surveys, we were careful to ask open-ended questions so that we could receive the most substantive feedback possible. The next thing we did, and I should explain that we actually did the part with management first, we conducted retreats with management and large group meetings with management to really understand what their idea of the needs assessment, what it should entail, and how we should frame these surveys that we would do with our other key partners, such as the patient groups, the staff, and the external partners. Finally, with patients, this was probably the most informative part of the survey that we found, and that was focus groups. So we did a number of focus groups, both with the Consumer Advisory Board and with some other small groups of patients, such as our Latino group on the main campus, who meets regularly to discuss needs in the Latino community regarding health care. We met with them separately from the Consumer Advisory Board. And finally, we conducted telephone interviews with external partners. And the important thing to remember about this is just that you'll want to schedule them in advance, and you'll want to talk to your senior management about who the best contact at, say, the equivalent of the Boston Public Health Commission or your state's Department of Mental Health, who the best contact would be at those organizations to conduct these telephone interviews. And for us, those usually lasted 15 to 20 minutes, and once again, we used the open-ended question format. In the broad area of what questions do you ask and what areas do you consider, what we looked at were, first and foremost, the gaps in service delivery. We thought this was really important to understand where all of our key stakeholders felt there were gaps in service delivery. And surprisingly, we found a lot of overlap between all 4 groups. Next, barriers to accessing care. Third was desired partnerships and collaborations. The idea behind that was, are there new groups that we should be partnering with? Are there groups that we currently have collaborations with that we could enhance? And lastly, we had a section always for additional comments and suggestions for our target audience. Finally, I'd like to discuss some of our findings. The first thing, which I've mentioned, is the 1 to 5 point scale is not enough. About 10 years ago, when we did a needs assessment, we used a simple 1 to 5 point scale, and we found it really wasn't substantive enough to then write a report on what our needs really were. So I would encourage the open-ended questions. Next is the timing, which I've already mentioned. You'd like to do it 6 to 12 months before your next SAC is due. You may also want to hold extended planning sessions with senior level management, and even use off-site retreats with your CAB, your Consumer Advisory Board, and with your Board of Directors and your senior management if possible, to really give the needs assessment the importance it requires. As Lee has mentioned, the needs assessment is really the backbone of your program. It will really help you move in the direction that your patients require and that your community requires. So it's really worth putting that extra emphasis and that extra time into the needs assessment. And finally, gaps in service delivery. The 2 areas where we found the biggest gaps in service delivery were with substance use disorder services and with services for victims of domestic violence, trauma, and other violence. So we found about 50% of our participants found issues in those areas, and that was across the board, from patients, from staff, and from external stakeholders. So since we've done that last needs assessment, one change we've made is we've really increased our substance use disorder services by expanding our Suboxone program, which is a program for opioid treatment. And before I move on and pass the mic to Victoria Deloney, I would like to just mention a note on research needs. I recognize that Boston Healthcare for the Homeless may have been founded before many of the other participants on the call or many of the other listeners on the call. So we've been using an electronic medical record for a long time, and we have a research department. We're fortunate enough to have a research department here in our organization. So if there's ever any advice that you'd like on research or specific needs you're looking for, such as Lee mentioned, the diabetic need, and you're looking for original research, it's something our research department could probably help you with. And you can ask through Julie, the organizer, to how to get in touch with me on that. So thank you, everyone. That concludes my presentation. And now I would like to pass the mic to Victoria Deloney.
Hello, everyone, and welcome. I'm Victoria Deloney, and I work for our local health department with Sacramento County Department of Health and Human Services. And today I will discuss how we plan and conduct our patients' needs and satisfaction survey and how elements from the survey helps us in the process development of our needs assessment for our budget renewal grants, or our SAC, as well as the community as whole, because we work closely with other homeless providers and organizations. Our Healthcare for the Homeless program is focused on outreach services using licensed nurses. We use registered nurses and public health nurses who go into the shelter sites and conduct triage assessments on clients who may be having acute or exacerbation of chronic healthcare problems. In addition, we conduct some well child clinics at a couple of our family shelter sites, and then we have a Healthcare for the Homeless clinic located in a highly impacted area downtown in the Loaves and Fishes area, where there's multiple service providers for the homeless in that one area. Health centers must demonstrate and document the needs of its target population, as Erika and Lee have discussed previously. And for us, we use our survey, primarily our needs assessment and satisfaction survey, for that reason in development of our needs assessment for our grants. The components of a community needs assessment and important criteria to address, as Lee and Erika already explained, and I list here for your review. And the type of questions that we ask for our needs assessment, we try to sync with elements that are required of us for our health center program requirements, as well as the elements that are required in the needs assessment itself. And we also look at community interest for other homeless programs, what type of questions they are looking for, because we try to work closely as a collaborative within our Healthcare for Homeless project. As part of our mission statement, I won't read the whole thing, but part of our mission statement is that we will achieve our mission without discrimination by expressing and respecting the dignity of others and working as a collaborative within our community. And so we work strongly with other healthcare providers and service providers who serve the homeless population. In addition to that, our co-applicant board, which initially was a Healthcare for the Homeless advisory board, but recently we have changed the structure, looking at the new PIN, and now we're considered as a co-applicant board, and they have always worked hand in hand with the county in developing our needs assessment survey, and they have a strong input in terms of recommendations of the outcome of our survey. Formulating questions for our survey. The co-applicant board is our guidance in formulating our questions in terms of what type of questions are important to the community at large, and we look at questions that we currently query and and require modification. So a strong community interest from our organization working with the same population. We compare data with each other, and remarkably so, most of our data syncs very well together. It helps us to collaborate on projects for gaps and barriers that are identified and work together. And also, the co-applicant board has a significant role in developing the type of questions outside of the questions needed for our grant narrative, because like the other two presenters noted, our population, special population, homeless, as well as migrant, refugees, are special and different and always need and require special accommodations or recommendations throughout the community. We try to work together and provide them. And I will go over a few of the results at the end of some of my slides here. Conducting the survey. A strong interest is reducing survey bias. With this said, none of the staff within the outreach staff, our clinic staff, conduct the survey or the survey interviews. We work close with shelter providers and other homeless service area providers, and they conduct our surveys for us at a special point of time. We usually try to do the survey in the summer during 1 to 2 days, or we try to do it during the winter. In the summer, we get more consumers coming to the clinic or different service areas seeking the cool-down centers for comfort, as well as the winter we get more clients coming in from the river and other parks and streets for warmth. So we try to conduct our surveys around those general times, either summer or winter. We just completed our 2013 summer survey, and I will share the results with you. Also, we offer the clients incentives for participating in the survey, and some frown on that as it sometimes could create bias because they're just doing it and may mark anything. But oftentimes, because there's such a strong collaboration and resources in our community, they don't want anything. They will participate in the survey. However, if those who have concerns about utilizing incentives and budgeting for incentives with your grant funding, we have talked to our project officer about that in the past, and as long as there are items that we could justify as a medical necessity, usually it's never really questioned. So we get things like first aid kits, hot cold mugs, undergarments, socks, hygiene kits, and reusable bags, and we offer those types of incentives for doing the survey. The query survey results, we use the Access database for all of our data that's coming in from the surveys. And we use Access because more than one person could enter data at a time. I use volunteers because we have a staffing problem within our county. As you know, budget decreases creates less staff. So I use volunteers and students from the local university who are looking for their intern hours. I use them readily for helping me with the Access database, entering queries, and a lot of IT students who love to run queries and cross-tabulations. So I have been lucky in that respect. We run simple queries and cross-tabulations, and the staff and volunteers, they get to use their skills and beef up their resumes at the same time while helping us serve the homeless. The review of the results are usually reviewed by our medical director, the clinic medical director for the county clinic system, as well as the program's operation manager, who is usually noted as the director on our homeless grant, the program coordinator, myself, and the Healthcare for the Homeless co-applicant board. All these individuals review the results and make recommendations. However, the final recommendations come from our co-applicant board. And from those recommendations, we work on our strategic planning, which is usually all year round. Survey results and recommendations that I will share today are medical conditions, primary needs, utilization of the homeless clinic, convenience of the clinic hours, clinic location, satisfaction with service. The first result is a medical condition. This question was phrased, what type of conditions do you have? Select all that apply. Mental health service is not a surprise. It's usually the highest one. However, years back, we had dental care that was neck and neck with mental health. And I'm glad to see it's gone down a little, but we still need to work on that. However, from that survey 2 years back in dental care, the advisory board then worked with local private dentists, send letters out to solicit for pro bono restorative dental care. And remarkably so, we got 5 dentists to participate, and that program still exists. Currently, we only have 1 dentist, but the board is working on soliciting for more dentists again through the community to get more on board with that effort. Unfortunately, the County of Sacramento does have an emergency dental clinic, but no restorative services are provided, mostly just extractions and palliative care. The next one was primary needs. That question was phrased, what are your primary needs? So this gave us a sample of what type of needs are homeless requiring. I highlighted in red clothing because we were all shocked to see that, because as we assume, many of our shelters and homeless service areas usually accept donated clothes. But recently we found out some of them have stopped accepting used clothing. And I wasn't aware of the number of organizations that stopped, and neither were some of the board members. However, our homeless board members clued us into it and educated us a little bit more about it and let us know that most of the homeless, when they do get clothes from the shelters or other service areas, they don't have access to laundry facilities, so usually they're getting clothes and throwing the other ones away. So currently the board is also working on strategic planning around clothing for the homeless. On one avenue, we've worked with our GYN pilot project where we're educating women about the importance of cervical cancer in groups, and then we're signing them up for pelvic exams, and then they get underwear. So that's one item of clothing that was, when queried more, it was underclothes. So we provide them underwear for meeting their appointment goals for their GYN services. Another question was, do you use Mercy Clinic Loaves and Fishes? And the majority of those surveys do use our clinic. It's called Mercy Clinic Loaves and Fishes. It's a collaborative clinic with Mercy Healthcare, Loaves and Fishes, and the County of Sacramento, where the county provides the health information system. Mercy provides a nurse, clerk, furniture, and some medical supplies, and the county provides a doctor and the pharmaceuticals. There's no funding exchange between the three in this contract, and it's just a wonderful collaboration. The next question I wanted to share was, are the clinic hours convenient for me? And for the majority of those who answered this survey question, the service hours are convenient for them. So we're proud to get those results. The clinic is not open full-time. Currently it's only open 6 hours a day. So we were concerned at one point. Is the location convenient for me? And where the clinic is situated is a high utilized impact area around Loaves and Fishes, because there are many services in that area within the Loaves and Fishes organization, as well as a park they call Friendship Park. And in the clinic, were they courteous and treated me with respect? 156 gave us an A. We graded it on a scale of A to F because we use a grading scale. We felt that our clients would be more comfortable doing A, B, C instead of letters, because they see A as being excellent. The Needs Assessment Satisfaction Survey, just an overview. It's important to sync your criteria needed for your grant. So the questions that we formulate, we try to sync also with what's required for our grant and for our health centers program requirements. Engage your co-applicant board. So our co-applicant board is very active in the survey development, administration of the survey, and the review and recommendations. Engage your community. We work closely with the community, so most of the time the community is using the results from our survey. Just recently, one group, the Health Committee with Sacramento Steps Forward, used the results from our survey and was awarded a grant to help with a mental health outreach, more outreach workers on the street for mental health clients. Alleviate bias by having volunteers or non-clinic staff conduct the survey interviews. Offer patient incentives, and it's a good tool for strategic planning. Each time we do our survey, some items stay the same on our strategic planning and we continue with those, but then it brings up something new, like the one we had now, clothing. Collaborate with other grantees and not just other grantees, but also other community advocates serving the same population. And thank you. I'll pass it back on to Julie.
Great, thank you, Victoria. I would now like to begin the Q&A session. We did receive several questions, but you can go ahead and continue to submit your questions in the Q&A pod. One question that we received, it was a request to have Boston's Needs Assessment Report shared, and we did add that to the documents pod, so you'll see there's an additional document in that pod that you can download from your computer now. We will also have these posted with the recording of the presentation and a copy of the PowerPoint slides on our website within 3 business days. Our first question, I know we have some non-grantees on our webinar today, and so just a little clarification. This question goes to Lee about the difference, or what is a SAC, BPR, and NAP. Lee?
Essentially, what you have is a SAC is the acronym for Service Area Competition, and that is open to anyone to apply for the opportunity. I think that when you're looking at doing a service area competition and you're thinking you want to try and compete against an existing grantee, you're going to need to get support from the community to do so. The new access point is essentially the NAP application is a grantee who's looking at a new point of access to provide service that may be going into another community, may be opening up an additional site. And the BPR I'm not quite as familiar with, so I'm going to ask my other co-presenters if they can respond to that. It's my understanding that it's the budget period review, and if that's correct, then it's a quarterly basis. So if someone else could provide some additional information, that would be helpful.
This is Victoria. The budget period renewal is for existing grantees. And when you get your first grant, you usually get a project period of 1 to 3 years. If you have a 3-year project period, every year, but during that 3 years, you'll do a budget period renewal report, and it's like a mini grant, just to let them know your performance, how you've been doing within your project period. So every year, you do have to respond to HRSA with a performance report. So it's called a budget period renewal.
Hello, and I'd like to move on to the second question in the queue. The second question comes from Margie, and it asks, are we required to have a consumer advisory board? As a FQHC, half of our board members are health center consumers, including one who is homeless and one formerly homeless. Can this count? So to respond to that, I would recommend that you speak directly with your project officer, whether you're organized as an FQHC that serves the whole community or one under Section H, 330H, just for the homeless, will answer this question for you. For a 330H, which we are, I would advise that yes, you do need a consumer advisory board unless half or more of your board members are homeless or formerly homeless. For us, we have about 1/3 of our governing board members who are homeless. And so for that reason, we also use the Consumer Advisory Board, and we find it's helpful in a variety of ways. So it's definitely worth pursuing. Thank you.
And this is Victoria Deloney again. I'd like to add to that as well. There's a new PIN that came out, PIN 2014-01, that gives you more information about clarifying governance requirements.
Sure thing. This is Erika in Boston. Victoria Deloney, I believe your question is up next, and I'll read it for you. It's, how do you provide surveys to those who are illiterate?
For those who are illiterate, we typically have someone on site that will either help them complete any documentations they need for their clinic visits. And like I said, for the surveys, they're usually conducted as an interview. So someone's reading the questions and the choices to them.
Sounds great to me. The next question is for Lee. Lee, the question is, in past proposals to HRSA, we have answered the question about need by relying on many of the resources that you suggest, but we have not compiled a written needs assessment report. Is a formal needs assessment report now required?
The answer is not exactly that you have to have a formal needs assessment document prepared. However, your needs assessment is part of your strategic planning process, and the documentation of the needs of your target population should be shared with your board of directors, and I highly recommend that if you don't have a formal needs assessment document, that you have the information presented to your board of directors and that the minutes of the board of directors reflect that they have been involved in the needs assessment process and that they support it as part of the strategic planning process, and show a motion in your minutes that they've approved that. So there's some kind of a document that can be referred to that shows that there has been a formal process and that the board has participated in it.
As coming up at the end of the hour, so we have saved the questions that were in the that were submitted in the Q&A pod. So we'll go back and reach out to those who have submitted a question that we haven't had time to respond to and follow up via email. If we could have one of the presenters advance to the next slide, that would be great. These next two slides provide online resources that may be of interest, including a link to the Council's Technical Assistance Request Form. I would like to remind participants that this PowerPoint and the recording for this webinar will be archived on our website at www.nhchc.org within 72 hours. A link of the archived webinar will be emailed to everyone who registered for this webinar once it is posted to our website. The second resource slide, if you could advance to the next slide, provides tools for data collection for your needs assessment. And the final slide, at the close of this webinar, you will receive a survey to evaluate this webinar. Please complete it so that we are able to improve your webinar experience. And I want to thank you, send a thank you to all of our presenters who did a great job, and for all of you for joining the Needs Assessment for Healthcare for the Homeless Grantees Meeting HRSA Requirements webinar produced by the National Healthcare for the Homeless Council. At this point, I would now like to close the meeting.